This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome everybody. It's the Not Your Doc pod. My name is Seth Gabriel, producer Seth, as they refer to me on the show, doing my best Vanessa impression as we are still making do without her. I'm here with my good friend, Dr. Charles Tadros, or as I like to call him, Dr. Chucky T. And I just made that up just now. So how do you like that?
That's pretty good for Not Your Doc podcast. I have more than one derogatory name that's fun to listen to. Actually, thank you for. I'm gonna probably tell that to my wife to see if she can parlay that into a daily thing for me. Thanks.
Yeah, that's a great SoundCloud rap name. If you ever want to get into like maybe making your own hip hop beats, you can be Dr. Chucky T.
I need stuff that rhymes and alliteration, stuff that sticks.
So in Vanessa's absence, I was talking to you last week, and we decided without her around, let's do a little guy talk.
Yeah,
Let's
sure.
ask some of these questions. Today, we're just going to go over 5 questions men should be asking their doctor.
At least 5 questions. We can go more.
Oh,
yes.
Yeah. Actually, in our research, we probably found a couple of thousand. You probably have already heard all these questions.
That's all right, yes.
At some point. But right now, we are going to ask these questions on a few men's behalf as they are men be. Yeah, I said that wrong. But anyways, we're asking on behalf of a few men out there that may be too embarrassed to ask some of these questions.
That's right.
So you ready to dive in?
Absolutely. Well, we should talk about why men don't talk about some of these.
Okay.
First of all, I
For
think,
sure.
Personally, a lot of times men don't talk about this because they didn't grow up talking about it. Smaller things, less important things, maybe as they're growing up as youngsters, about their health or about what's normal or not normal. And that's what I find is a lot of people don't even know what normal should look like or feel like, whether it's feelings or body part changes, etc. So that's the very first thing. And oftentimes the spouses or parents, or I'm sorry, their spouses, and oftentimes the parents, whenever they're that young, it's parents and teachers, are not sure what to say or how to say it. Sometimes they kind of brush it off or go tell people to look it up in a book or a website. So that's kind of the way I grew up. My parents never talked about sex to me. I had to figure it out on my own. And so that's the first thing. The next thing is, of course, if you go to a physician, nurse practitioner, physician assistant, I will tell you it should be matter of fact. It should be, oh, you want to talk about this? Sure, everybody wants to talk about this. So one of the things I wanted to make sure is that people don't feel that special about bringing up questionable, stuff that they may consider embarrassing. If we say, oh my gosh, stop, and nobody ever talks about this stuff, then it makes people a little more shy and embarrassed. So I want people to kind of feel comfortable, and that's why sometimes whether you go, if you ask questions for people like us or through a website or whenever we're going to do live chats eventually, it's easier sometimes to talk to a stranger in certain ways. The persons who know you tend to have a better history on you, and I can make more specific recommendations, but we'll make some general observations and recommendations here. Once again, it's not specifically to any one person or any one group, but it's just a way to start thinking about things, and you can take it up with your own professionals that know you better.
Okay. Awesome.
Yeah.
And I fall into the category of the people who are afraid of the answer.
Yeah.
And you're probably familiar with this category as
sure.
well, right? Okay. So, and like I get up every day, I'm like, I'm alive and breathing. I'll go to a doctor someday. I'll ask these questions at some point. But for right now, I'm enjoying the ignorance in a way. It's bliss.
It is.
Ignorance can be bliss sometimes.
If it's not squeaking, there's no reason to grease a non-squeaking wheel, obviously. So you're kind of we're going to talk about kind of what guys may quote unquote squeak about, what they kind of may bother them sometimes, and there's tons of other things.
There.
Yeah, there's tons of other things too.
That was clever. Are you ready for question number 1,
sure.
Doctor? Okay,
Yeah.
Chucky T. The first question, with annual physicals now covered by insurance, what screenings do I need?
Sure. Well, first of all,
And let's talk about age too.
Yeah, so it's not everything is automatically covered. When people are talking about insurance covered screenings, for decades and decades, insurance companies, especially Medicare, did not cover wellness visits or screening visits. Screening means don't have any symptoms, but you are at risk for something, whether it's hypertension or alcohol or diabetes or prostate cancer, breast cancer, cervical cancer, all these things, you may not have symptoms, but you're at risk for them. Your right age, your right sex for certain things, right gender, so that you could potentially have prostate cancer or colon cancer, diabetes or heart disease or blood pressure, cholesterol. So screening test means that, and for many years, insurance would not cover something if you didn't have symptoms already. If you haven't already had a heart attack or you had symptoms of increased thirst for diabetes, et cetera, they would not cover things. Now we've known it for decades, but finally insurances have jumped on board that they will cover screening physical exams, sometimes even screening tests like a cholesterol panel or blood sugar before you have any symptoms. So that's the first thing. You always have to check because it's money, and you always have to check. Don't assume because it seems right that insurance should cover it. So that's the first thing. For certainly for pediatrics, which is not my age group, but for pediatrics, there are wellness checks because oftentimes wellness checks go with immunizations whenever you're very young, and so that's a very important piece of it. And wellness, and oftentimes people, in order to participate in sports or camps, needed physical exams filled out, and so oftentimes that was important. So those are times in youngsters' life where they tend to be seen more because that's when they discover things that you were born with or happen early in life. Born with means congenital, happen in life early. Is the other aspect that if you wanted to pick up kidney disease or something, not necessarily born with it, but you develop it early in life, they tend to pick it up earlier, and that's the pediatrician. Pediatricians are typically seeing you until age, depending on how big you are and other conditions you may have, 16, 18, or even 21. So some people can even go through college by still seeing their pediatrician. Most people don't. And then from there, you tend to go to an adult primary care physician.
Real quick, if you're in college, do you still go to the room with the balloons and the clowns and sit on the table and get a lollipop?
So unfortunately,
afterwards?
I get 6'1" guys and not the gals so much, but 6 foot, they have to go sit with the 13-year-olds.
Tiny bed, the tiny chairs.
Right. So that's one motivation to move on, especially if you're big. If you have early puberty and you're big boy.
Unless you get a sucker at the end of it, then that's hard. It's hard to walk away.
Those treats. But anyway, so that's really important to have whenever you're growing, to have a medical home in pediatrics because they get to know you, and this is everything from ADD to depression to anemia to blood pressure issues to menarche, which is the start of menstrual periods, school academic issues, parenting related issues, sibling rivalry, all that stuff. Pediatricians are really good at this, and so that's very important. And that's also time that they can do physical exams. This is from everything from blood pressure to scoliosis with spinal curvature, to flat feet, to asthma. All these things are picked up in typically in childhood. So testing is not that much. Testing is typically done in youngsters. They'll do probably a lipid panel, a cholesterol panel, a blood sugar, check your blood pressure, and that's not necessarily every visit. Certainly not every visit, but that's some of the items that they'll be checking. If you have a family history for something early in life, that warns them that they should look in it for you. Bipolar disease, substance abuse, other things that may run in families. Thyroid issues, type 1 diabetes, all these things. Type 1 is typically not inherited, but anyway, that's important for to have a good history to be able to tell the pediatrician. And once again, not usually a lot of blood tests in pediatric age groups. 18 and above, that's when we start getting kind of adult. These are pretty much all youngsters are adult size by 18. Most boys stop growing about 18 years old. Most women, girls stop growing about 16. Some people go into college, obviously. So so physical exams are much less frequent. Routine physical exams are much less frequent, where you have no symptoms. You're just going in annually and stuff like that. So typically it'll be much less frequent after 16 or so, maybe every 3 years or so, that somebody will go be seen by a primary care physician. Somewhere in your 30s and to 40s, that's when we probably should be getting something routine, just into a habit. That's when hypertension, obesity, marital problems, all sorts of things start, financial problems, all sorts of stressors start coming in, and somewhere usually into your mid to late 30s, into your 40s. And certainly by the time you're 50, we're looking at annual exams for men and women. We're talking men here mainly today. That's once again, because the older you get, the increased risk for arthritis and depression and obesity and cancers, and autoimmune diseases, etc. So there's you get accumulation of chronic conditions that tend not to go away. In other words. And that's why we end up seeing you routinely at that time. And so then testing, so the typical general testing, and once again, it's different for every age group, but the typical general testing is a comprehensive metabolic panel, which is a blood sugar, kidney, and liver functions, and electrolytes, sodium, potassium, calcium. That's comprehensive or complete metabolic panel, a CMP, Charlie, Mary, Peter, CMP. That's one panel. Another panel is a CBC with differential and platelets. So complete blood count with differential, which is a different part of the white cells, and platelet counts. And that looks at your white cells and the breakdown of the white cells. These are the ones that fight infection and are part of leukemia and lymphoma. There are the red cells, which will carry oxygen. Also, if they're too low, it's called anemia. Also can be part of cancers. And then the platelets are the things that help make scabs and clots. So we have a comprehensive metabolic panel, a complete blood count, a urine analysis, or UA. Urinalysis, I always mispronounce it. I call it urinalysis as if it's two words, but it's urinalysis, which is one word. And that looks at your blood sugar in your urine, protein in the urine, red cells in the urine, white cells in the urine, and some liver-related functions in your urine. Those are the big ones. Occasionally, you'll have a lipid panel, cholesterol. This is the total cholesterol, HDL cholesterol, the high-density lipoprotein cholesterol, the quote-unquote good cholesterol, the LDL cholesterol, low-density lipoprotein, or the quote-unquote bad cholesterol, and then there are some other numbers that include in the cholesterol panel. And then occasionally people will get a thyroid study, which is a TSH, typically thyroid stimulating hormone, which is we call it fourth or fifth generation. I can't remember which generation we're on now, but usually that's enough to screen for thyroid function. People who have enlarged thyroid on physical exam or have other thyroid symptoms, buggy eyes with high pulse and weight loss and palpitations and anxiety. Those are potentially hyperthyroid patients. They may need more than just a TSH, like a free T4. It's another blood test for thyroid. If you're overweight, snoring, lethargic, diabetic or pre-diabetic, thickened hair, breaking off of hair loss, and other things like that. Constipation, maybe hypothyroid. Those patients also TSH plus a free T4, a free thyroxine blood levels can be helpful. So we're talking about comprehensive metabolic panel, or complete metabolic panel, CBC, complete blood count, lipid panel, cholesterol panel, and thyroid. Those are the big ones. For men later in life, if you're 40, if you're African American or have a family history for prostate cancer, then there's an increased risk for prostate cancer and for being more aggressive early on. So PSA, prostate-specific antigen. This is for a blood test for your prostate cancer risk, is usually at 40 and above. We'll come back and talk about that. And if you're Caucasian or low risk, don't have any family history for early prostate cancer, then 50 or above for a prostate number every year is potentially okay. American Urological Association differs then from some of the other organizations where they look at prostate numbers and say, wait a minute, don't just automatically get one because you're a certain age. What happens is a lot of people will get them. They'll be mildly elevated or borderline high. And then that goes into this diagnostic misadventure where we send you to a specialist and we do more tests and biopsies and kind of all sorts of things kind of come together when you have an abnormal test when it comes to the prostate. Not everything that raises the prostate number above 4, that's the usual magic number for older people. Younger people is above 2 or above 1.5 sometimes for the PSA. So if you're younger, if you're 40 to 50, they're probably looking at a PSA less than 2, probably potentially even less than 1 or 1.5. So understand, even though the PSA may have a normal range of from 0 to 4, for young people, if we're testing younger people, 40 to 50, that they may want you less than 4. Certainly above 2.5 and certainly above 4, for older people, we want those people may end up having to have more testing and go see a specialist. Things that raise prostate numbers, and this is why it's not just a cancer number for prostate. After sex, it can raise your PSA no matter what age you are. After masturbation, same thing, like sex, it can raise your PSA. Riding bicycles a lot can raise your PSA. After somebody touches your prostate, like a doctor feeling your prostate as a rectal exam and during a physical exam can raise your PSA. Benign growth, so benign prostatic hypertrophy or hyperplasia is just a BPH, which happens as almost all men grow older, starting probably in your 40s. That can also even though it's benign enlargement of the prostate. that can also raise your PSA, and certainly prostate infection, prostatitis, bacterial typically can raise your PSA. And then last, cancers can raise your PSA. Prostate cancer is an adenocarcinoma of the prostate. I once early in my practice had a person who had metastatic prostate cancer to the ribs, and the PSA was normal. And it was a special type of prostate cancer, and very few people get a sarcoma. Those are very rare that would not raise your PSA. It's adenocarcinoma, which is almost 100% of prostate cancers, is the one that raises your PSA. So that's why we get into trouble trusting tests blindly and calling them one thing. Prostate PSA, prostate a specific antigen is a cancer test for the prostate. It actually goes up with all sorts of other things besides cancer, including cancer. So those are some of the things, and when we would typically test for them.
Wow, that was interesting. There's a lot of follow-up questions. But you said you riding your bicycle with the seat on.
Yeah, right.
We'll raise the PSA. And
it is. It's true. That's one of the problems we run into is that we sometimes, if we see a borderline elevation of PSA or moderate elevation, but not or even high before, then we will have people repeat it after stop sex, stop riding bicycles or stationary bikes, and we'll have them stop for a week or two, and then have them do a repeat PSA, and oftentimes they'll be improved. Yeah. It's important for people to know that. It's not always cancer.
All right, so we're going to get sexual here for a second with the next question. We're not going to go, this one's a little vague, so we're not going to go specifically into PE or ED or any of these other two-letter acronyms, the things men are especially embarrassed to bring up sometimes to their doctor or anyone else. So we're just going to throw it out there. I'm not feeling as sexually vital as I'd like. Could something be wrong with my health?
Yeah, sure, absolutely. So we're talking about men again. We'll talk about not young males, not boys. So first, I differentiate sex drive from erections. So sex drive is the want to have sex, the desire to have sex, the libido, the horniness, and then the functioning, the hydraulics, the nerves, and the blood vessels that go to the penis. Are you able to get an erection and maintain it to get satisfactory intercourse? So I just kind of segregate those two. So that's the first thing. Typically, I look at number one, the patient's age. Number two, their medications for depression, if they've had diabetes and diabetic medicines, etc. All of these things can matter in terms of both libido and erections. Alcohol consumption. People severely underestimate alcohol can cause weight gain. The beer gut, and weight gain tends to lower testosterone. Testosterone tends to lower libido. Testosterone is usually not related so much with erections, but libido, the horniness, the want to have sex. People kind of mistaken that, thinking that if they just jack up their testosterone, everything will be fixed, and it's not true for a lot of people. So first of all, like I said, so I will look at the desire to have sex. Are you having marital problems? Are you having depression? Are you on medications that can mess with your libido? You want to have sex, stuff like that. So unfortunately, some of the best antidepressants also decrease your libido. So the Prozacs and Zolofts and stuff in the world tend to help with depression, anxiety, and PTSD, but they can decrease your want to have sex and decrease your ability to have erections, and certainly decrease your ability to ejaculate.
All kidding aside, that is a hell of a thing to weigh out.
It is. It's a big deal for young men. That's one of the bigger causes for them: weight gain and sexual dysfunction. Are not feeling okay. I'm not depressed or anxious, but I just feel bland, blah, flat. Can't get excited, can't get sad. Those are the big reasons why people don't want to stay on medicines like SSRIs. So the want to have sex, the desire to have sex, like I said, those are some of the big things. Alcohol, like I said, and obesity. It turns out obesity is one of the causes that drives down testosterone. So people tell you that you have low T or low testosterone. I'll get into that a little bit later. Then one of the things to do is to lose weight. If you're overweight, that tends to raise the testosterone automatically without any shots. So that's the next thing. Then erections. The problems also come from medications, from alcohol, because as you know, if you're drinking and stuff like that, you may not be able to. If you're really drunk, you may not be able to perform. So stress is the other big thing. Performance anxiety, right? It's kind of like stage fright, but also even if you have a partner that you've a loved one, a partner, a spouse that you've known for years, one or two times where you can't perform, all of a sudden gets into your head, even if it's not a stranger or anybody, one night stand, it gets into your head, and it becomes becomes a performance issue. So that's the other thing. And then of course blood flow issues. So blood flow, both remember your penis has arterioles. These are arteries with kind of valves that put blood into your penis, and then the veins that take blood out of your penis also have valves. So you pump in blood and you close off the veins leaving the penis, and so if you close off both valves, entering and exiting, and then you'll have a rigid penis for intercourse. So if you have poor blood flow in, so blood vessel problems going in, such as with diabetes or with hardening of the arteries, atherosclerotic arterial disease, and some other inflammatory arterial diseases that can cause problems with inflow of blood into the penis. Outflow, it can be from a variety of things, including varicose veins, where you can't close off the venous valves. So that's kind of where we end up with the blood flow issues. Nerve issues. This is actually neuropathy that we see in diabetes is one of the problems. This is part of the autonomic nervous system. So that's it's a parasympathetic and sympathetic nervous system have to work together to get erections and to have ejaculation. So it has to be working well enough. So that's the other thing. And occasionally we have fibrosis or hardening or thickening of some of the tissue in the penis. Peyronie's disease. It can sometimes will be painful if you have an erection, or you get a crooked penis with an erection, and that's typically a fibrosis. May be a part of an autoimmune problem, but that also can cause erectile problems or painful erections or difficulty having erections. And those are the big things that I think about. There are a bunch of other things. If you haven't slept well, is another thing that can cause problems with wanting to have sex, the desire, as well as to have efficient, effective erections. Yeah, that's roughly about right. Any other ones you've heard of?
Oh, no, I think you covered, there's a lot of stuff I hadn't even heard of in there, but I thought that was pretty interesting right at the beginning. You're talking, you got to differentiate what, between these things. And I think that's pretty important to talk to your doctor so they can find out, is it do you have anxiety when it comes to performance, or do you have a medical issue that's physically stopping you? So there's a big difference between, do you want to have sex or can you not have sex?
And I have not got into the kind of the hormone stuff. The testosterone is driven by the brain, by gonadotropin releasing hormones, and so there's a whole feedback loop that involves the brain, and you can have faulty hormonal drives along the way. So FSH and LH, follicular stimulating hormone, and luteinizing hormone, that could be an issue that cause problems with libido and eventually erections. So it gets more technical from that standpoint, but that's the usual stuff. Occasionally, prostate stuff can affect erections. For instance, if somebody's had prostate surgery, which were the nerves that go around the prostate capsule, if they're damaged, that'll also give you classically a problem post-operatively, potentially permanently, of erectile problems after surgery for prostate cancer. So there's a bunch of other ones that are more, that we may see. Yeah. So important to see a good primary care guy or gal, and then also a urologist, which is usually the next step if your primary care person can't help out. Most people forget back 30 years ago, whenever Viagra came on board. Bob Dole, people forget when Bob Dole lost to...
God, was that commercial not the hardest thing to watch?
Yeah.
Bob Dole and his wife talking about him carrying his erection.
After Bob Dole lost to Bill Clinton, Bob Dole started making Viagra commercials. Yeah, that's right. And so Viagra was initially indicated for people with post-operative, post-prostate cancer, prostatectomy surgery that had erectile problems, and people with diabetes, advanced diabetes that affected the nervous system and caused erectile problems. So those are the two big reasons that Viagra was indicated for. I don't think it ever achieved any other indication for in terms of erections. But the vast majority of the people that I wrote scripts for were probably functional erection problems. They have not had surgery, did not have diabetes or advanced diabetes. So the vast majority of prescriptions that we wrote for, that was never, by the way, Viagra was really never covered for the typical person that I ever had to see and gave prescriptions for, were for functional issues that may have been better treated with exercise and cutting out alcohol and seeing a therapist, a talk therapist and relationship therapist, than getting Viagra. But the kicker is Viagra, I remind people, Viagra can help people with or without erectile problems. So it can help a person with, irregular erections have a more rigid erection and last longer, and it certainly can help people that have erectile problems. So it's not a way. People say, well, I took Viagra and I got a better erection, therefore I must have ED or erectile dysfunction. The answer is no. It helps all sorts of people with that. So that's not a diagnostic criteria for erectile problems. The problems with the Viagras and the Levitras and the Cialises of the world is that these are all work through the same mechanism. The problem is that these things can give you headaches, can give you Cialis, especially muscle aches. Some of these can give you heartburn and chest fullness. So it's not a pleasant experience to get a good erection with these drugs. Sometimes it's lasts several days. Cialis has got a long half-life, so you can have several days of muscle aches from Cialis, for instance.
And they say after 4 hours, consult your doctor. 4 hours still seems like a long time.
It is. Most men, despite what people think, most men, 10, 15 minutes of sexual activity is probably more average. I know what people say and read and think and watching porn. It's not even close to that. So that's why foreplay and other things about knowing about your partner, a lot of things besides coitus with completion to ejaculation is important to recognize that other things that are very important in intimacy that are besides intercourse, because intercourse for a male is heck, 15 minutes would be long. 2, 3, 4, 5 minutes, at most for most men.
It's crazy. Bob Dole lost to Clinton, who had the exact opposite problem. But that's for a different.
That's right.
That's for a different show.
That's another show.
Yeah. All right. And I will say, if you cut out drinking and add exercise to your life, you could probably knock a few things off your list of physical and mental health problems.
Oh no, a large chunk.
Yeah.
Stress
for
reduction,
sure.
Absolutely. Weight loss helps a lot of different things. But stress reduction through exercise helps everything from heart disease to erectile issues. You are correct.
What a great segue, because our next thing we're talking about is heart disease. Here's a question I think a lot of men out there. In fact, you get asked this a lot. You don't even have to volunteer this information or ask about it. You actually get asked in a lot of medical consults and a lot of medical forums. Yeah. I'm worried. Here's the question, doctor. I'm worried because several relatives in my family have had heart attacks. How can I tell if I'm at risk for heart disease?
You are. If just being a male, you puts you at risk.
Having a heart.
Yeah, just having a heart puts you at risk. That's correct. That's
being
a good point.
Alive means you will die.
That's right. That's the highest risk factor for dying is that you're alive to begin with. But no, we know that fatty streaks start happening in your teenage years. This is back in Vietnam. I said this on another podcast in Vietnam, when young boys, 18-year-olds are young boys to me, young boys were killed and they would do autopsies. These boys would already have fatty arterial streaks. This is cholesterol lining the arteries already in their heart arteries. So we know that cholesterol builds up already, fatty lipids that are stuffed inside the lining of your arteries. Your media is called the media of your coronary arteries. So we know that it happens in young people, maybe genetics, maybe also dietary stuff, oftentimes with a combination. Smoking seems to accelerate it, obviously, too. Diabetes accelerates it. So the quickie answer is absolutely. The older you get, and I would argue, the stuff that we see when you're in your 50s started in, like we said, in your 20s and below. So anywhere along the line, it doesn't mean that you have to have an EKG or a stress test starting whenever you're 15 or anything like that. But anywhere along the line, if you're smoking, if you're diabetic, if you're obese, if you drink too much alcohol, if you don't exercise enough, all these things put you at risk for having problems later in life. The number one killer in developed worlds is not malaria, is not eaten by Nile crocodiles. It's heart disease, coronary artery disease, specifically with ischemic heart disease.
Yeah. Nile crocodiles is still top 10 though. Watch out.
They will get you. I heard those Nile crocodiles are very aggressive compared to the American alligator. But seriously, you are correct. So if you have a family history, and it's especially important if the family history is what we call early coronary artery disease in your family. So below age 60 for men in your family, first degree relatives. Below age 50 for women in your family, first degree relatives. This is a mother or sister type of first, which means the first degree is a mother, brother, mother, sister, father type of, and that's the first degree relatives. And then second degree relatives are your uncles and cousins, etc. So then also, like I said, not only do you have the genetics from your family, especially if it's early heart disease, and even if they smoked or even if they had terrible cholesterol, and you say I don't smoke, it still puts you at risk. It's people don't understand this. Even if it's something that's quote unquote potentially reversible in your family members, if they hadn't done certain things, that it still counts against. They don't ask how that person got their heart disease. They just count it as a risk factor for you, and so that's the thing. So we know that obesity, sedentary lifestyle, recent heart attack, repeat heart attacks, all these things put you at risk for another heart attack or a primary heart attack in our case. Smoking, all these things, and elevated LDL cholesterol and the oxidized form, and a couple of other things about ApoA and ApoB. But anyway, those are the big risk factors that can be monitored and modified. That's right.
All right. Well, moving along, we are going to go with question number 4 here. Doc, I'm urinating more than usual. Should I be concerned?
Yeah, sure. It bothers you enough to ask me. Absolutely. So first of all, I want to know, how often did you used to?
Yeah,
urinate?
that's going to be my question. What's considered a lot?
Yeah, what's considered a lot? What did you used to? What did you used to urinate? And most people are not born or not in their first decade or 2 of life or 3 decades of life. They never complain about it because they don't think it's an issue. But most if you're in fluid balance, what you put in comes out. So if you're hydrated, if you drink a liter of water, you'll tend to pee out close to a liter. You'll have insensible water loss in breath, and some in the stool, some in your breathing, some in your sweat. But if you're in water balance, if you're not dehydrated, people who are dehydrated, obviously, they may not pee at all. That's a part of the problem. That's what we see in kids, and that's what we see in the military. You drink, nothing comes out. So you got to be careful about that. That means that your body needed to hold on to that you were deficient in dehydrated, deficient in water. So that's just a general. And the stronger the yellow, the more dehydrated you probably were. So as you can imagine, you can drink enough water so it's practically clear like water. So water in looks like clear coming out. That's in water balance. The darker your urine, the smaller volume. The darker it means that even though you drank a lot, it's concentrating a lot of waste product in a small amount of volume that's going into the toilet. So we want to have all the waste product in a large volume of water in order to kind of to make sure that you're in fluid balance. So that's the first thing. If you get up at night to pee, that's abnormal typically. It depends on how much you drink before you go to bed. But whenever you're a youngster, you didn't usually have to get up at night to pee for most of us. So that's the first thing. So if you get up at night to urinate, that's nocturia. So that's the first thing. So if you have it once or twice per night to have to get up to pee, it's time to talk to your doctor. And I'll come back to why people have to urinate frequently or at night. During the day, if you go to urinate, you sit on the toilet or stand above the toilet, the urinal, and you empty your urine, and as you practically walking out, pulling up your zipper, go wash your hands. Yes, wash your hands, even with the urinating. And you practically have to turn around and go back. That's also a hint, even if it's a few dribbles, but you get the urgency to walk right back. That's a urinary urgency, and that needs to be also addressed. If you're going to pee every few hours, unless you're a chronic water drinker, that also is an issue. So that's the other thing. If you feel the urge to pee, but there's not much there, you get a few dribbles, that's also an issue. So all these things you should bring up to your doctor, and you can describe it as such. What these are. They are. So the typical stuff. Number one is that people who drink too much water and too much is pretty rare, but there's some people that do drink excessive soda. So they don't think it's water because I just drink coffee. I drink this. Well, all liquids are water based that we put in our body. That's the first thing. Next is caffeine and maybe other products in certain drinks tend to stimulate our bladder to squeeze and our prostate to go into spasm. So people have urinary frequency and not much urine there. It may be something that's irritating your bladder, your prostate, the smooth muscle in your prostate, or the bladder, which is lined with the muscle that makes it squeeze. So there's maybe not much urine there, but you get the urge to go because it's from an irritating product that we're ingesting. It's usually caffeine or something in the drinks. So that's the next thing. Next thing is big prostates. So the prostate sits in the bottom of your bladder, between the bladder on top of it, and then the urethra goes to your prostate, and then it goes out to the penis. So if your prostate is enlarged or is in spasm, then that also may not allow allow your bladder to empty all the way. So you got a high pressure, so you push out some through the tight prostate that's in spasm, and you can't empty your bladder all the way, but you clamp off, your prostate clamps off, but you still have a semi-full bladder. So that's when you have to keep going back frequently. It's because your prostate won't let you empty your bladder all the way. That's very rarely is prostate cancer prevents you from emptying all the way. It's usually just overactive bladder, overactive or spastic prostate, or overactive bladder. The other thing that men and women get is OAB, overactive bladder. This is a spasm of the bladder. Doesn't have much urine in it, but it feels like you have to go. So that's the other thing. So that's the other way. It's called OAB. So we've talked about kind of drinking too much fluids, overactive bladder, spasm of the prostate, enlargement of the prostate. It's unlikely going to be urinary cancer of the prostate that's causing you to go too much. The other things are if you're diabetic and you don't have good control of your diabetes, whether you're type 1 diabetic that requires insulin or type 2 diabetics that typically doesn't require insulin early on, may require insulin later. If your blood sugars are high, your body has got to get rid of your sugar somehow. They can't get it into the cells because you don't have enough insulin, so it puts it through the kidneys out to the urine, and sugar in your urine drags more water out with it. One of the signs of poor blood sugar control is that you get up at night to pee or you have daytime excess peeing. So that's not enough. That's excess sugars in your bloodstream. Either you're eating too many sugars or you don't have enough insulin to take care of the sugars in the bloodstream to lower your blood sugars. So that's the other thing. There are people with heart failure. This is excess fluid because your heart is not pumping efficiently and correctly. These people will have excess fluids. Their legs will be swollen. They may have fluids on their belly, fluid around their lungs, and especially if they lay down at night, they can have to get up frequently to pee at night. That's the other cause for. But yeah, there's a reason to go see your doctor, talk to your doctor if you, for any reason that your urination has changed in volume or frequency. Yeah, good question.
Yeah, and every time we talk about men's health, the prostate is brought up at some point. That's terrific for men.
Women don't have a prostate, men do, so we get to talk about that just for men. Yes.
Yes. Yeah. Any medical topic for men, it's always the prostate is always brought up at some point. I also want to point out when hydrating, the temperature of the water and the speed that you drink it are also huge if you're trying to hydrate.
Is that
we all want to chug ice cold water when we're dehydrated and it's hot out, but that's the exact opposite. You want your water if you're feeling dehydrated and you don't necessarily have an IV bag or something you can stick in. If you can get some room temperature water and sip on it, there you go. You'll be all right. All right, because correct me if I'm wrong, but the body has to bring that water temperature to the body temperature.
Yeah, so
or it's just going to pass through.
Right. So part of it is that's true that your internal, even though you may feel hot outside, unless you're having heat exhaustion and heat stroke, two different things, that your body internal even though your surface temperature may be feel high, and you're sweating to try to cool the surface temperature, your internal temperature is still 98.6, whatever around that stuff. So your water temperature, if it's 32 degrees, it's not going to be 32 because it's ice, but above 32, let's say it's 40. Your body will want to dump heat into your stomach where the fluid is to equalize, come to equilibrium with respect to the temperature for the water. So even if you're not feeling hot, I think it just is a satisfying feeling and stuff like that. But yeah, that's I've not heard about the room temperature water, but certainly there's nothing wrong with room temperature water. Absolutely not. But yeah.
All right, and we got one more question. I thought of this. This was something I'd heard a while back, and I thought I'd ask you. So I've heard that when men get to a certain age, if they were to reproduce, you're facing higher risk of developmental problems in that child. How true is this, and what are some information surrounding that?
Yeah.
What is the age? What are some of the problems that can occur?
Yeah, that's a very good question. Well, for decades, we've known that for women above age 30, they increase the risk of trisomy 21. So we know that for women, if they're even at 30, and a lot of women are 30 and above whenever they have their first child nowadays, they have other things that are going on in their lives, as opposed to decades ago when women would get married relatively younger and have children relatively younger. So what we've known for years that women who are just 30 and above are increased risk for autism, or not autism, for Down syndrome for their babies. So that's one thing. thing. But we've now known for years that men, their sperm now if they're advanced in age, increases the risk for a baby having autism. So that's one of the things. So, and this is the challenging thing whenever we deal with today's society's needs and our social norms, is that people feel that they can be just as great as if they're 23 as a 33 or 43 or 53. You and I, who was it that just had a
Robert De Niro?
Robert De Niro.
I want to say, I could be wrong without looking it up. I want to say he's 83, and the girl his girlfriend that's pregnant currently, or just had the child, I believe, is 29.
Yeah, I bet you that they had chorionic villus sampling and other testing to make sure for the baby, because that puts the baby, his age puts the baby at risk for having medical issues. But anyway, God bless them. So we don't have, it's not a free and clear runway. You could start all your reproductive years. So that's important to kind of say. People can still make their own choice, personal choice, cultural choice, but I want people to understand medically. We just because people can get pregnant when they're in their 40s doesn't mean it's easy to get pregnant. It doesn't mean it's that they can carry the baby as long without having support from a fertility specialist, etc. And men's ages, that's why we're here. Men's ages do affect his fertility. Obviously, it has a number of sperm that he can produce, the quality of the sperm, and also the risk for autism for the baby. And fortunately, we can get in utero testing. Amniocentesis and chorionic villus sampling are the two big ones to look at certain genetic abnormalities, so we can get a hint of what's happening. Ultrasound is the other way. But yeah, we're getting to a point where we've had decades of where we have more choice of freezing eggs, freezing sperm, so that we can choose later to have babies, whether it's in the original woman's womb or a surrogate person to carry a fertilized egg and sperm from the original mom and dad for the baby. So we've heard about it certainly in celebrities who have surrogacy, who use surrogacy kind of routinely. So they say they talk about it out loud. Kim Kardashian, I think, has had several surrogate children. So I don't keep up with the Kardashians, unlike the show. I avoid it actually. But part of it is that it becomes part of the cultural talk about what's available, and it's not necessarily as available to the rest of us because of money and other things. But yes, absolutely, you have increased risks and increased issues. Not absolutely, never, but increased, and that's important to know the comparative words. Yeah.
All right, one more guy question.
Sure.
With Aaron Rodgers going to the Jets, will the Bills still win the AFC East?
You are better versed, everybody. My son-in-laws are better versed, and you're better versed than I am, because I don't follow football.
Okay, well, the question is, yes, the Bills are still probably going to win the AFC East.
Okay,
The Jets will be a wild card. We'll say that, but that still remains to be seen. Well, Doctor, this was fun.
Yeah, What'd you think? Right. Not bad. Not bad at all.
I think Vanessa would be proud.
Yeah,
for the most part.
I think she'd be okay with it. I think she'd have more refined, more incisive questions and grill me on some of my general statements.
Nice. Fun. All right. Well, if you have any of those questions you want to ask the doctor anonymously, you can contact us on the website, notyourdoc.pod.com, and there you can also listen to past shows, check out the blog itself. Dr. Chucky T, Dr. Tadros. I'm sorry, everyone around the office and everybody is going to start calling you that, and you're going to hate me for it. I have a feeling.
That's all right. It'll work. I think they'll know who I am.
And you can contact us about anything. It doesn't have to be some anonymous, embarrassing health question. Just any questions or concerns or any topics you want to hear on the show. Hit us up, notyourdocpod.com. Doctor, thanks so much. This has been fun. We'll hopefully see Vanessa again soon. Hopefully she hears this and doesn't hate this episode too much. I think she'll enjoy it quite a bit. All right. Well, we'll see you next time, Doc.
All right. Bye-bye. Thanks, Seth. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.